Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good afternoon, everyone, and welcome to PerfWeb 45. And Tammy Sparacino's Journal Club number 8.
Correct.
So want to welcome everyone here. Get through the housekeeping notes if I can. Our sponsors, LivaNova, Siemens, and HET. Please check them out. Would really appreciate you doing that. Social media. We have Facebook, we have Twitter, LinkedIn, YouTube. You need to like, follow, share us, and you need to click that subscribe button and also the bell notifications, okay? Websites and contact info is perfweb.us and perfusioneducation.com. And listen, we'd love to hear from you if you have some input on maybe some journals that you would like us to review. If you maybe have, if you'd like to be part of our faculty, we're always looking to expand it. So please reach out to us. We'd love to hear from you. Our call-in number, when you see this, you can call us, be live on the air if you'd like to. We'd love for you to do that. Most people, kind of like when you go to a conference, it's always the same few people that will go up to the microphone and never say anything. People, for some reason, don't like calling in and being live on the air. But please do. We really want to start utilizing this tool. We've had it for a long time. Some people have. We've gotten calls from Portugal and a lot of other places. And it's really cool when they do call in. So please use it. Call us in. Be live on the air. It's good for you. New MediWeb app. Real quickly, you can go to iTunes Store and you can, or the Apple Store, I'm sorry, and the Google Play Store. And it's the critical care app for perfusionists. There's also an IV dosage and rate calculator. Now that IV dosage and rate calculator is in the critical care app for perfusionists because it's not just for perfusionists, for critical care, for ECMO specialists, for a lot of different classes of people that may find that very useful. But for perfusioners, quick calcs, there's all kinds of things. But it also has the IV dosage and rate calculator. So it's great for ICU nurses, critical care nurses. Really can help them quite a bit. So check it out on the Apple Store and Google Play, and it's $2.99 for the big app, 99 cents for the small app, and please check it out and buy it. You know, that's what we want. You know, I need 1 million sales. Okay, that's all. I think we're up to about 30 or 40, so we got a little ways to go. Okay, if you can help me out there. All right, let me introduce you to our panel. since this is the Tammy Sparacino Journal Club, I thought maybe I would introduce you to Tammy Sparacino first. You all know her. I'm not going to go through a big, long introduction, but this was her brainchild to do this journal club. And and we are doing it a little differently. So the journal club is really only the first 5 minutes, kind of talking about the article, but then we get into the weeds, if you will, about the topic. And that's really, something happened. What went up? John, there he is. Thought we lost him. And that's where really the rubber meets the road, in my opinion, where we really learn a lot.
Right.
We discuss a lot of.
We're not going to critique the article. We're going to use it as a topic discussion point.
Absolutely.
Starting point.
Very good. And then, as you all know, I've introduced John so many times. Both of these professionals' CVs are on, or bios are on our website, thelibrary.perfusioneducation.com. But John is coming to us from Orlando, Florida. He is a stalwart supporter of the program and a great contributor. A tremendous amount of experience. He's working on his master's degree, right? Master's, John, or PhD? Master's? Yeah, and right, that's right. And so, and you do a lot of ECMO out there where you are, so you have a lot of experience in that realm, but in a lot of other topics as well. So welcome everybody to the program. We're just going to jump right in, and I'm going to turn the microphone over to Tammy and get her slides up, and she can talk to us a little bit about the article that we're going to be discussing in terms of the therapeutic modality.
Okay, good evening everyone, good afternoon. Today we are going to be discussing an article that was published in the Journal of Cardiac Surgery, and it's a case report. It was published just over the summer. It's covering, it's actually a series case report, so that makes it kind of interesting. We got more than just one case to discuss, but it's the treatment of cardiogenic shock and peripartum cardiomyopathy. This is a case series from a tertiary ECMO center. It took place over in Germany. I'll just read you the abstract real quick. So peripartum cardiomyopathy, also known as PPCM, occurs towards the end of pregnancy or in the early months after delivery without any previously known structural heart disease. Development of a therapy refractory cardiogenic shock is described in the literature with a limited number of overall presented cases in the very young patient cohort. To provide the differences and key points in therapy of end-stage PPCM patients, we present a case series of 4 young women with PPCM referred to our department to potential VA ECMO support. Okay, again, this is taking place over in Germany. All right, why this paper was published. There is not a lot of published literature on treatment of these types of patients on ECMO. There are a few things out there, but I think the significance of this study for these authors was to be able to take the patients that they were referred and just kind of follow them through and see the different methods and outcomes that were a result of ECMO. Okay, the problems to be solved are just the feasibility and the success of ECMO as a modality for these types of patients. We'll go through the cases really quick. So there's 4 altogether. So this is case 1, a 28-year-old. This is her second pregnancy. 3 days post-delivery, she had a 10% ejection fraction. They implemented a heavy medical inotropic support, and they were able to avoid ECMO altogether. She was discharged 10 days later, or 10 days after admission, with a 48% ejection fraction. So that one was obviously a success. Case number 2, 25-year-old, first pregnancy. She was actually coming in for a planned abortion due to fetal hydrocephalus, and she had a history of myocarditis post 1 year. But she had come in with a 10% ejection fraction with the onset of a new AV block. ECPR ECMO was performed 1 day on ECMO. She had a spontaneous abortion. ECMO was successfully weaned on day 4, and she had a 40% ejection fraction. They used medical management and plasmapheresis for the next 4 weeks. She needed ECMO again. ECPR was performed. She was on that for 3 days and successfully weaned with a 45% ejection fraction with no neurological deficit. Then 2 months later, still in the hospital, ECPR was performed again. She was unable to wean. She was put on a BiVAD for 3 days. She went into severe multi-organ failure, no sign of myocardial recovery, and she died. Case number 3, 21-year-old, first pregnancy. This is 2 weeks post-delivery. She had a 15% ejection fraction, moderate mitral and tricuspid valve insufficiency. They tried medical inotropic management, which failed. They initiated VA ECMO while she was awake. She had LV distension. A tandem heart cannula was implanted. Continued LV distension. They surgically placed an LV vent through a media sternotomy and were successful with unloading the LV. ECMO was weaned after 8 days. She was discharged 1 month later with a 30% EF.
So before you go to the next slide on that, so that tandem heart cannula, that's the that was a left atrial then, right? So it was the transvenous and then a transseptal puncture.
Yes.
And then that wasn't enough.
Right.
So the mitral regurgitation wasn't enough to keep the LV drained, so they
Yes.
they did a sternotomy.
Correct.
That is a big problem.
Yes, it is. Okay, case number 4, 20-year-old, first pregnancy. Now this one happened actually while she was pregnant, 30 weeks, 20% ejection fraction. She had severe shortness of breath, severe mitral valve stenosis that was unknown prior to this. Emergent C-section was performed. VA ECMO was initiated. They did an interventional mitral valvuloplasty. She then resulted in severe mitral valve insufficiency. They replaced the mitral valve. They continued the ECMO support during the procedure, and after she needed it for respiratory support. They had trouble weaning for that purpose. She was successfully weaned on day 5. She had a procedural stroke at some point and was discharged to a neurologic rehab on day 10 with a 20% EF. Okay, we kind of went over this. These were all VA ECMOs. They were all referred to this particular facility because it is an ECMO center, and they had experience with these types of procedures. Here's just a summary of kind of some things I told you about for the comparing the patients, but this is put in a table form, which is real easy to compare. You can see that column number 1 is going to be case 1. Columns that are numbered 1, 2, and 3 underneath case 2 are all that same patient because there were multiple ECMO runs. But you can see that we had recorded EFs issues starting and ending, what the inotropic supports were, whether they were vented. Then we have here whether they were put on ECMO and if it was ECPR. You can see only case 2, the patient that did not survive, received ECPR, and only case 3 required any LV unloading. All were able to wean except the patient that died, and then the duration of support there. All right, these are the total outcomes for them and the resulting EFs on discharge. You can see all patients but 1 survived, and we had a 48% with the first one who did not go on ECMO, and case 3 who survived 30%, and case 4 20%. Okay, so their conclusions. They concluded that these PPCM patients are at a high risk for many complications when cardiogenic shock occurs, that you should always start with a inotropic medical management strategy, and then if that is not enough, then any kind of support that you need for mechanical circulation support for myocardial recovery. And they, in their particular study, they looked at the tandem heart and LV vent, Impella, And they also mentioned the IABP should all be considered, although they did not have any experience with that for this particular article.
Mm-hmm.
All right. Then we can discuss this article, and what were your thoughts on it?
I mean, I think it's amazing to me the obviously the youth, the age of these patients is very low, and of course, you know, the one patient died. What was the reason that they had the recurring problem? Was that associated to this PCCM, or was it something else?
Well, that's what there was no detailed explanation to that, but you know, their concluding statement on that particular patient was no myocardial, let's see, hold on, what did they say? Multi-organ failure without a sign of any myocardial recovery. So they're just saying that the PPCM caused the myocardial problems, which then...
Well, how'd they get her weaned off ECMO and then have to go back on ECMO? That's the part that I'm a little bit confused about, is
I don't know.
how much duration of time. Yeah, I really don't know what happened there. That seems odd.
For three
And then
times. Three times she was on ECMO.
Yes. And then the last patient leaving the hospital with an ejection fraction of 20%. That's pretty low.
Yeah,
for someone that young.
Well, and in reading about this particular, I was not really familiar with this particular syndrome at all, and in reading about it, it can have lifelong effects.
Mm-hmm.
And some of these women, their hearts are never going to fully recover.
Do you have more information, or is that the end of your slides? I'm not sure.
That's the end of the slides for this article. We
Okay.
are going to talk about this topic in more detail, but I didn't know if you wanted to discuss specifically this article or had any comments or questions.
No, just those. I mean,
Yeah.
really, I think it. You know, we can talk about our anecdotal experience, but ours was different. It was a pulmonary problem versus this. I've never seen this.
Yeah, I haven't ever seen this either. John, do you have any experience with this particular type of patient for ECMO?
Well, we have had experience on a couple of cases. Actually, I'm sure that it was clearly defined as you have on this article, but I think it's important for our audience to understand the difference between this particular syndrome, which is really a little bit unknown etiology, right? I mean, we don't know what's bringing this on. We don't know why some recover fully, some don't, some recover partially, and then you have a case there where a young lady eventually died, and she had to, months later, she came back, 2 months later, you said, came back to the hospital,
Well, I
went
don't think
back
she
on
ever left the
ECMO,
hospital.
No,
and,
I think
and
she
she
was
ended up succumbing.
She never left the
Yeah,
hospital.
she didn't
John.
leave the hospital, but she was in a step-down.
Step-down unit.
Yeah, she
in
was
the
in a
hospital.
step-down
Yeah,
unit.
she never went home.
Yeah.
Oh, she never went home. Okay, she never went home. I got you. So, but I wanted to clarify for the audience, if they're listening, you know, almost all pregnant women have a syndrome, what people say is congestive heart failure-like, and it's due to, you know, as you guys well know, you know, a little bit of fluid overload, but also the compression of the fetus on the IVC and the venous return, right? So usually you get swollen feet, and then you have aggravated it sometimes with fluid overload, and then even you can get too much fluid, and the heart actually becomes in a state of congestive heart failure where you actually have fluid accumulating in the lungs. This is really not that. This is something totally different, whereby there's some type of acute, unexplained cardiomyopathy that's going on in some of these otherwise healthy young ladies.
Correct.
And it's not something that I think I've ever read about, so I'm glad you brought this article up, Tammy, because it's not something that, like you just said, not terribly familiar with it. But I know we have had at least a half a dozen in the last couple of years, peripartum or postpartum mostly, women that have had to end up on ECMO in our unit. And most of the time, they end up doing a pretty full recovery and going home. And, you know, I'm going to look into this further now that you've brought this article, you know, to our attention, and see what I can learn a little bit more about this in our experience at work, and see. But, you know, I just think it's really interesting that Do you know the occurrence rate of this?
Yes, actually, I'm going to get into that when we get past this article. But yes, I'm actually going to touch on a couple things that you were talking about. I was just hoping with the kind of ECMO experience that you have working in these larger facilities that you might have some personal experience with it, because I have not any at all. And like Joe said, we've done a few related to pregnancy, but they were VV ECMO and not this particular problem.
Mm-hmm. Mm-hmm.
Well, we've had I think we have had a couple that were VA ECMO, and it really was in. I know one in particular. I remember it was. She was actually a few days. Actually, she was delivering. She was actually delivering the baby via C-section, and we had to run to the delivery room, which was actually her patient room. She wasn't even in an OR.
Oh, right.
And basically had to eventually put her on VA ECMO, and she just went into a full-blown cardiac collapse. She actually had CPR while they were still suturing up the C-section. We had CPR. She ended up actually doing very well in the end, but it was a really scary kind of case. And she had a little bit of a high-risk pregnancy. We have those high-risk pregnancies that come along.
Mm-hmm.
What is it, preeclampsia? I think that's mostly what we've seen, right?
Mm-hmm. 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 Yeah, you get real hypertensive.
Right, right. And we're going to talk a little bit about that too.
Proteinuria and stuff like that.
Yeah.
Okay, well, let's go on. Let's go on to Tammy's slide.
Okay, so we'll get into
our
topic here. So what we're going to talk about is peripartum cardiomyopathy and ECMO applications. And just real quick for terminology, just for clarification, it was first named peripartum, but it also includes a period after the baby is born. So it would be postpartum. Those can be used interchangeably. PPCM can refer to either. I believe it most commonly is in the last trimester and up to about 5 months post-delivery, and it will still be classified this same thing. Okay? All right, first off, I needed to for sure understand what this was. So I found an article that did a really good job of just kind of explaining it, not in relationship necessarily to ECMO, but just in the syndrome itself. And this was published in Circulation a few years back, actually in 2016, but this is actually kind of a trending, newer topic. There isn't a lot known about it, and even when you search the literature, specifically for ECMO, there are ones that are reported, but no one has really come out with guidelines of how we're going to treat these and when are we putting them on ECMO and what's the survivability. There's just not a lot of data out there. Okay, so let's talk about it a little bit. It's specifically defined, or specifically has been seen back all the way into the 1800s in published literature, that it's just heart failure associated with pregnancy, and in the peripartum period as well as postpartum. It was poorly defined until around 1971 when they actually named the syndrome. Otherwise, it was just heart failure due to pregnancy. That's what they called it. Then in 1999, we had the first criterion defined, which is an EF less than 45%. Then further, over the next 10 years or so, they started adding some additional criteria. So it's cardiomyopathy and reduced EF, usually about less than 45. It's usually at the end of pregnancy, immediately months after. And they must have no previously known structural heart damage. If they're going to have any other kind of comorbidity that could cause this, then they don't classify them this.
Well, I don't mean to interrupt you or break your flow up, but your fourth case in the article had severe mitral stenosis, which can explain a lot of what was wrong there.
Right, correct. That is correct. So it was undiagnosed, and most of the articles that I read said this can be a real problem for even knowing how often this occurs, because just like John said, a lot of this early symptoms are things that people further along in pregnancies are going to have anyway, and so they can be overlooked for the severity, and they can just not be reported at all, just depending on the doctor's experience and their views and how the patient's expressing it and all those sorts of things. So mild cases likely go unreported. Yeah.
Interesting.
Okay, so the causes and incidents. So the cause is largely unknown. There's some potential causes that have been proposed, and that's viral myocarditis, nutritional deficiencies, some kind of autoimmunity. I thought this one was the most interesting, the microchimerism, and do you know what that is, Joe?
Microchimerism?
Yeah.
Mm-hmm. Yeah.
Okay. I had to look that up, so I found it really interesting.
Yeah, because that's a common potential problem with
transplants.
With allogeneic blood transfusions and transplants. That's right.
And so, of course, I knew what it was, but I'd never actually seen the word for it. But, of course, it makes sense if you're pregnant that you have, cells that are different from you in your body. So that is actually a pretty interesting potential cause. And then newer research are looking into vascular dysfunction, hormonal insults, and underlying genetics. Worldwide, there's not a lot of reporting, so it was hard to get statistics. I did find in this article they were specifically looking at a lot of cases in California, but overall in the United States, it's anywhere from 1 in 1,000 to 1 in 4,000 births.
That's a lot.
Yeah, it's a lot.
I mean, I don't know how many births there are. Go ahead. I'm gonna look up while you're talking how many births there are in a day, and this is worldwide. I'm assuming that would be a worldwide number.
Well, they said it's not reported a lot worldwide, so these are just looking at the United States, but they say they're hot spots sometimes. So I think I read that Haiti had a hot spot, and theirs was almost like 1 in 300. And so that's what started making people think that there might be some genetics involved. And again, these are just the incidence of the syndrome, not of it becoming severe enough for ECMO. Okay, some at-risk factors, which these are interesting because we didn't have some of the demographics on our case study from our article that we're reviewing, but all our patients were below the at-risk age. So the age greater than 30, it's a 50% of the cases that are reported are greater than 30 years old. We only have data specifically for the United States, but 40% of the PPCMs reported occurred in the black population.
Wow. And just for reference, there were 3,788,235 births in 2017.
Worldwide?
No.
U.S.?
In the United States.
So say that number again so I can put it in context.
3,788,235. So you keep going, and I'll divide that by. I'll take the higher number, 1 in 4,000, not 1 in 1,000.
Yeah.
I'll do 1 in 4,000.
Okay, and then predisposition, the preeclampsia, chronic hypertension, basically any type of hypertension, even if it's gestational hypertension, those are going to have a higher incidence. And then multiple gestations, twins, triplets, etc.
That's about 1,000 cases, 947, 1,000 cases a year.
Yeah.
That's a lot.
Yeah, especially to not really be that familiar with it.
Mm-hmm.
Yeah.
Can I interject something here? I think you have an interesting slide. Because the last slide, one of the factors that they're looking into in the research was some type of hormonal insult, I think the way you phrased it on your last last slide, Tammy.
Yes.
And if you look at what you're showing here, there's some indications here that maybe hormonal is playing an issue. You have 50% of the people over 30. You have people that have multiple gestations, twins and triplets, and those two things make you think a little bit that there's some hormonal factor going on. Would it not?
Yes, I think in this article they said it was about in normal populations, including all types of pregnancies that have been reported for this syndrome, they calculated it to be somewhere around 1% or something like that. You go up to twins and it's up to 3%. So it's quite an increase. Okay, so let's talk about its presentation and treatment. It has the typical heart failure symptoms, which is again why it might get overlooked if they remain mild. But you're going to have tachycardia, edema, LV dilation, shortness of breath, pulmonary venous congestion. The treatment for mild cases is going to be medically managed with diuretics, nitrates, hydroxyline, ACE inhibitors, beta blockers. Severe cases are going to get inotropes, and then hopefully this type of order of progression, you know, an IABP, ECMO, an LVAD, a BiVAD, and a transplant. I did find an article that did a case reporting on a patient that developed this syndrome and then later got a transplant.
Wow.
Yeah. Okay, so let's talk about ECMO as an effective tool for this. Uh-oh. Something happened. Oh, there we go.
Nope.
There we go. Okay, so this is another article that I found. It was really the most comprehensive article that I could find that was up to date. This one was published in Interventional Journal of Cardiology in July of 2020, so very timely. And it was a review article that looked at the ELSO registry and any of the ECMOs that were registered with this as the underlying cause were then cataloged, and we've got this, the results and survivability. Now remember, it had to be listed that way, so there's probably other ones that went on that just had some other you know, reason why they went on ECMO.
They just didn't diagnose it the same way.
Right, exactly.
So you're saying it's an underreported problem.
Yes, because the diagnosis or the definition is so loose. I mean, they've only started trying to fine-tune it just in the last 15 or so years, and even now it's still very broad, broad criterion. Okay, so their data review results, it was retrospective. They looked from 2007 to 2019 ELSO registry. The primary outcome measure was just, did they survive to be discharged? So it was a real a broad review, but I thought that would be really good for us to discuss since I had estimated that probably we didn't have a lot of experience with it amongst ourselves. So they looked at 88 VA ECMO patients. 72% of the patients were weaned off ECMO. 10% of that 72 were transitioned to a VAD or received a heart transplant. 64% survived for hospital discharge. Of the 72%, 11% were ECPR, and of the ECPRs, 60% survived. The factors associated with decreased survivability were, you know, neurologic complications, specifically central nervous system hemorrhage. All right, and that's what I got.
That's actually, can you go back that slide?
Sure.
So for VA ECMO, because that 64% is almost really a VV ECMO number. You know, because with VA ECMO for, let's say, sudden cardiac death or refractory arrhythmia, something like that, the survival is, you know, I think 40%.
Yeah, it's lower.
This number. So 64% is pretty good.
Well, and, you know, it's probably that most of these people are, you know, it's a young cohort. So they're, if they really, truly don't have any or don't have a lot of comorbidities, maybe they have hypertension, you know, maybe they're overweight, they're going to, of course, have better survival rate, you know.
So I have a question for you. And we can, I think, you're done with the slides? There's
no
more slides?
No more slides. We can take the slides down.
So question for you is, if you have this PCCM occur in pregnancy A, and then you survive it, what happens with pregnancy B, and do we know?
I don't think we know. I did not see anything on the same patient with this syndrome happening multiple times. I didn't find any articles exploring that at all. I think that probably has something to do with, because of the causes are unknown, we don't know if it's going to be every time. And I think it's that way with quite a few things that can happen when you're pregnant.
I got an article. I did some reading up on this, and I did find an article with that exact question.
Do you have slides, John?
If you have a first pregnancy and you experience PPCM, if you make a full recovery, your heart comes back to the full ejection that it was baseline, then gynecologists and obstetrics are still fine recommending that the lady have additional children without a problem. But it's those who do not fully recover, and even if it's just a minor decrease from their baseline cardiac output from when they were, before they were pregnant on their first one, they don't recommend a subsequent pregnancy for anyone who has not made a full cardiac recovery. But anybody who has made a full cardiac recovery, they say the risk is close to normal again for those.
That's good to know.
Yeah, that's very interesting. Do you have any slides, John?
No, I didn't have any slides on that. I did do some reading up on it because, like I said, this was a good topic that I didn't feel like I knew much about. So I did get a nice comprehensive article about it.
Good.
And I think it's a really interesting topic.
You want to share some additional highlights, or what do you want to do? Because I've got some questions.
Yeah, go ahead with some questions, and I'll see about some other highlights that I have here.
Yeah, sure. So, we have anecdotally, we have two cases.
Recently.
Well, one was maybe a little over a year ago, and that was a pregnancy where her ejection fraction was very low, it was like 20%, really struggling. I think that patient was about 38 weeks, pretty close to delivery. And of course, to me, I think that Dr. Matoyer was who was taking care of the patient. And I think the cardiologist wanted the patient on VA ECMO, but she was hypoxic. And, at the time, Dr. Matoyer felt like the cardiac failure was secondary to hypoxia, not due to a primary cardiac problem. So we put her on VV ECMO. Well, they did an emergency C-section. And she had classic preeclampsia, and I think, I think her problem ended up really being pulmonary edema and hypoxemia secondary to that. But he put her on VV ECMO, and as soon as the baby came out and had the Avalon, in fact, they were inserting the Avalon while they did the C-section. And both the child and the mother did great. Then fast forward a few months ago, we had a similar scenario occur, only this patient, we were having to give this patient massive amounts of pressors. Now, they did the C-section, and in this particular case, the child didn't survive, but she was almost really an ECPR type of scenario. We had used huge amounts of pressures on her, and she survived, but she, lost, either all or parts of limbs, and but she had two other children at home, had not had this problem, and I'm wondering, because I had never heard of this either, if that really was this PPCM and not, what we thought it was. So I think, is there a histologic? Is there some? Is there any laboratory analysis that can be done to verify what it is?
Nope.
Because it's 1,000 cases a year in the United States, using the higher number, 1 in 4,000.
Yeah.
But if you use the lower number, 1 in 1,000, that number gets a lot higher. So 4 times more, right?
Yeah.
So it seems odd to me that we don't know what this is. I've always considered it just to be a preeclampsia type of scenario.
Well, and I think it was so it wasn't being recognized as its own syndrome. It was just a complication that could happen with pregnancy that causes heart failure, not specifically this. And so there hasn't been a lot of research. I mean, most of the stuff that I read said there is a lot of areas that need to be explored for this because there's just not enough known. There was quite a bit of interest in the hormonal insults, as they call it, causing different vasculature constriction. And because your hormones are going up towards the end of the pregnancy, there were some really technical articles that were outside the scope of what I could even explain. But the diagrams were easy enough to see that they were, they actually give, I'm trying to think the name of this particular drug, and it's no longer FDA approved in the United States, but at one time it was, and I think they gave it to one of these patients. Let me see if I can remember the name of it. But it basically, it acts on hormones and stops lactation, and they said that that can help with recover some of these patients, not necessarily ECMO patients, but patients that are experiencing this type of cardiomyopathy. And I wish I'd have written down the name of it.
That's okay. Take your time. While you're looking that up, I'll ask John a question. So, John, do you have any experience doing ECMO on a patient that is pregnant and that you are not too early for to do a C-section? And how did that go? And how, what was the outcome of the case or cases that you did? And what were some of the major considerations?
Well, we have not that I can recall, but it's funny you say that, because about 3 or 4 weeks ago, I was talking to a chief friend of mine down at University of Miami, and they had a pregnant woman actively on ECMO, and that's not the reason I called him, so we didn't talk about it too in depth. But as far as I recall, he was telling me that she was doing well and seemed like she was going to do well. But that's a good area to explore.
And the baby
as
as
much
well.
ECMO as we've done, I can't recall an actual pregnant.
I'm curious about that too.
Ongoing pregnancy.
Yeah, because I don't remember what does or doesn't cross the placental barrier.
Yeah,
I'm not sure. How do you deal with the anticoagulation? How do you deal with?
I did actually look up just for my own general knowledge, because we don't get a lot of pregnant patients. I remember studying about it a little bit in school, but that was a long time ago, and I've still yet to have a pregnant patient in the OR. But the article that I read, just talking about cardiopulmonary bypass and pregnant patients, is they have, for whether it's CAD or valve replacement or whatever it is that they're going to do, some kind of cardiac intervention where they have to go on bypass, they do not have any greater mortality rates than women that are not pregnant with similar, comorbidities.
But what about the child?
Or the child.
Really?
Yeah.
So because I understand the patient.
Yeah.
But so you're saying, okay, that's very interesting.
Yeah.
I find that very interesting.
Yeah, I could have talked a whole bunch about that too, but it was outside of our scope, because I found it very interesting too. It's just not something that you typically are going to see.
Well, let's open. Yeah, the phone line's open. If anybody out there has any experience having a pregnant patient on cardiopulmonary bypass, I have one, but it was when I was in school too.
Yeah.
And it was a patient that had mitral stenosis, had a mitral valve due to rheumatic fever. Believe it or not, I used to see cases with rheumatic fever, and we had done a mitral valve like a year and a half prior, and then she had left, and she stopped taking her Coumadin, and of course it was back then it was a mechanical valve, and she clotted it off, and we ended up getting her back and got her to the operating room, but both she and of course the baby at that point in time, she was pregnant, both died, but they didn't make that. But I remember we were on the phone with Texas Heart at the time, trying to figure out, what can we give? How do we do this? How do we do that? It was a very dramatic situation.
I think I'm gonna make sure and look up some stuff on that and see if we can talk about this.
Pregnancy and cardiopulmonary bypass.
Yeah.
I think that'd be a really
interesting topic.
But if anybody has that experience, they can call in. That'd be great. Or send a chat to Facebook or whatever you want.
Tammy, I've got a couple. This article that I pulled. Interesting. It says here that there's higher risk factors. Now, you pointed this out, that if you don't have any other coronary or cardiac viral infection or inherited diseases or coronary disease, but besides that, excess.
Oh, you froze, John.
Oh, wait, you froze. I think he's going to say excess fluid causing venous
Yeah.
congestion, maybe.
John.
Oh, did I lose you guys?
Yeah, John.
Am I back?
Yeah, you're back.
You're back.
You have to start that all over
Yeah,
again.
start again. You said excess
So
something.
on this article, you had pointed out that if excluding people with, some type of heart condition, coronary disease, or viral infection of the heart, but they're saying here that excess alcohol consumption, smoking, and obesity are higher risk factors for this as well. And The other thing that I find interesting is the treatment. You also pointed this out, but it says this in this article. So if you have somebody who is a cardiomyopathy, and their basically ejection fraction is greatly decreased, right? I mean, to the point where they're having to go on ECMO, it's going to be pretty serious decrease in their cardiac function. And two of the treatments, and you listed it as well, ACE inhibitors and beta blockers, in addition to like diuretics. So, if you think about ACE inhibitors, it's a vasodilator, and a beta blocker is actually going to slow and decrease your contractility. And you think to yourself, well, why would you be doing those things in a patient that already has poor contractility? And what they found out is the reason why these treatments are pretty effective is that the heart, in these cases, benefits enormously from rest. And vasodilating the patient, so there's less resistance for the heart to pump against, and beta blocking and basically slowing the heart rate down mostly. That rest in these particular conditions seems to be a very beneficial to patients, which they should be trying long before they probably went on ECMO. And I found that kind of interesting that's the treatments for it.
Well, and also going back to that drug I couldn't think of the name of, but I found it here. It's and hopefully I'm pronouncing it correctly, or at least closely. It's Bromokryptyn.
I had never heard of that.
Okay, so it's taken orally, and it says additional therapeutic approach. So I didn't know what it was, so of course I had to look it up because this article doesn't really talk about it much. And it was approved by the FDA for a while, but it is now no longer on label for that in the United States. But it essentially stops lactation because I guess the prolactin. Well,
that's probably stimulated by.
Yeah. So the prolactin apparently does something to the vasculature that constricts them. So that kind of goes along with everything that we're saying. If we're going to vasodilate them, if you're a smoker, you know you're going to have constricted vessels. So those kind of all do seem to go hand in hand.
Well, yeah, you just brought it up. Obesity. Obesity seems to be, although the lady I was telling you about, this last case that we did, I did that case, she wasn't obese.
Yeah.
There was nothing wrong with her, actually. She was young, healthy, well, good nutrition. I
wonder if it's that part, because remember, if we think about what was my slides, some of the proposed, links or some of them were nutrition, of course, but genetics are in there too, and there's a lot that we don't, if we don't know any biomarkers for that particular thing,
or having it checked.
Yeah, right.
Because you have to have your DNA map to know whether you have this or that or whatever it is.
Right.
Yeah, it's very interesting. It really is. So, this is a really interesting topic. I think we need to follow up on it.
Wow.
It sounds like something we need to follow up on seriously.
Yeah.
So, John, can we shift gears? And if anybody does decide to call in on this, we can always go back to this topic. So here in Houston, and I just got back from Querétaro down in Mexico. I was down there, and they too, the city is seeing a very significant spike in new COVID cases, as we are here in Houston. However, I talked to a heart surgeon I was visiting down there, a friend of mine, and they're seeing the spike in cases, in positive tests, but not an associated spike in hospitalizations and need to be on the ventilator. I don't think we're seeing it here in Houston. At least our volume hasn't really done anything different. But the spike has been going on now for a little while.
I mean, in the ICUs,
we haven't seen it in the ICUs. No, I think we would have by now. Frankly, I really do. I'm surprised. So, what are you? What's going on there?
Joe, you make a great point. There's something strange going on. I'm hoping that the early treatments are better, but we have in Florida huge spikes, and our cases in the hospital are way down. We're way down on cases. We had hundreds and hundreds of people in the hospital, and all those sections of floors have completely emptied out. We're down to basically one ICU plus some on ECMO, and that has actually decreased as well. So I see in the news the spike of cases, but you're just not seeing that being admitted to the hospital for some reason.
So what's your thoughts on this Regeneron, the antibody?
Oh, yeah.
What are your thoughts, John? Any? I mean, are you guys using it there, or what? I mean, do you have any experience? I know it's experimental. It's it's still considered experimental, but it certainly seems to have done something. I think it seems more effective than convalescent plasma.
Yeah, I mean, I don't know how the incidence of how much we're using it here, but I think that there's two things that are interesting about this COVID topic. I think people are more social distancing and wearing masks more than ever, yet the cases are spiking more than ever. That's one thing I think is peculiar.
Yeah,
and then the fact
peculiar.
that we're seeing a spike in positives, but yet the hospitals are not seeing, at least our hospital, we're not seeing very many COVID patients at all.
And you're an ECMO referral center, right?
Say again?
You're an ECMO referral center.
Yes, absolutely.
Right.
Yeah, and we now have, I would say, 1/3 of our ECMOs are non-COVID. They're back to the ECMO cases that we were doing before, and the COVID patients that we have, most of them have been on for quite a while. 14, 20 days plus. We have occasionally a new one. We'll have one or two new ones maybe a week. But if you look at the list of ECMO patients that we have, it's about 1/3 now are non-COVID, and we have about 18 patients on ECMO, and the others are COVID. But by the way, a huge percentage of those that we still call COVID are now long since been negative as well. They're just suffering the effects of the severe inflammatory response and so on that we know now is such a huge part of the COVID response. And but it seems to me that it's slowly decreasing as much as the cases are spiking. The actual hospital crisis is actually less than ever from what I can see.
Yeah, I'm wondering if that's happening also. I need to call up my friend in Nashville, Matt, and check with some other folks.
And see what's going on.
Because I'm really curious, because we're not, I keep hearing the spike, and it's a significant amount.
Yeah. 60,000 cases today, right?
Yeah. But it's like the second day, I think, that it's been that high, and yet we're not seeing it. So I find it interesting. And John, you brought up something very interesting too. And Tammy, I'd like to get your thoughts on this. If you ever go to ViewMedi is a really cool site. If you ever get a chance to go to, I would recommend to my colleagues, to John, you guys.
What's it called?
ViewMedi, VUMEDI, I believe. And I'm positive that's right.
Okay.
And there was a virologist who was giving a lecture on masks and the effectiveness or lack of effectiveness of masks. And it was very interesting. And he was using interesting numbers, like, okay, so if you shed 100 viruses, how many are going to get through this type of mask?
Yeah.
How many are going to get in through that type of mask? And then what does that really translate into as an end result? And when you start talking about the numbers, which are very low, the numbers that we are able to comprehend, 100 here, 100 there. But when you start getting into the hundreds of thousands, it starts to become really difficult to grasp and understand. Like, okay, well, how many does it take to actually infect you?
Yeah.
And so all of these nuances, and John, to your point about we're being more cautious than ever, using social distancing. Everyone's wearing masks, and yet we're seeing the highest spike ever, and it's just, I don't understand it. I can't really understand why.
Well, because economies are no longer shut down. Don't you think that has something to do with it? We may be social distancing, we may be wearing masks, but we're still going more places than we had been going when we,
Then what's the point in social distancing and not wearing masks? It sounds to me like the only way to not transmit this is to stay sheltered in one place and not have any contact with anyone else, which is fundamentally
it's impossible and
well,
ridiculous.
It's not just impossible. It would be devastating to the world.
Well, I don't think that
It is impossible to do. You're right.
Maybe I have a different perspective on what we're trying to accomplish, but we're not trying to not transmit it at all. It's going to get transmitted. It's a disease, and we don't seem to be able to stop any disease necessarily effectively.
Well, not a virus.
Not a
like
virus
this.
anyway. Just completely. It's just a limit, right? I mean, that's what we're trying to do, is limit the amount of infections.
Right. So, but my point though, and I think that that's right. I agree with you. Flatten the curve, whatever you want to call it.
Whatever.
But the point is, this was John's point. More people than ever are wearing masks. More people than ever are socially distancing. Yet the number of cases is rising at a precipitous rate.
Well, didn't CDC just change their guidelines too about the amount of time that you need to be in the vicinity of someone to be able to? Because remember, it was, what was it? Was it 6 minutes or something before?
I don't know.
Now they've lessened the time, so it's like even more infectious is kind of the point. I think
It sounds to me. I mean, I'll just tell you what common sense tells me. Okay. And this is very commonsensical. I don't think the masks and social distancing are doing any damn good at all. When you look at the data and you look at the facts, it's sort of hard to say masks and social distancing are working because our numbers are going up.
Well, part of
but it's not getting translated to the ICU. So has it mutated to a less virulent form?
Yeah.
Are we becoming more adapted to it? Do we really have herd immunity and we don't realize it yet? Where we have had an exposure and our memory cells are able to then produce antibodies, so we're not having as bad a reaction to it as a first exposure? I just don't know which it is.
I have a question about that, and I wish I would have remembered to look this up. I didn't realize we were going to discuss this today, but maybe John will remember. Reported not too long ago in the news was the first known man, I believe it was, Utah, but I'm not totally sure, that was reinfected, and his second infection was actually quite serious. John, do you remember reading about this? But the first one was mild, and they were saying that, perhaps if you don't have, a serious enough infection that you're not going to have immunity from it. So
I don't know. I mean, I think that the only way, if you are infected with a virus and you clear it, there's only one way it got cleared, and that was you had to have developed antibodies. And so, I don't know. I can't answer that question, but that's one case.
Yeah, no, but it's interesting though.
It's interesting, but it's it can be there's so much unknown about this. I think that's the thing that bothers me the most, is that we don't know.
Well, and that's part of the problem, is that everyone wants the answers, what we need to do, how we need to act. We need the vaccine right away, all of those things on a unrealistic time scale. That's why things keep changing, is because people are putting out statements before they have any real long-term research or data or observations to be able to make those rules or assumptions or anything. I just don't think it's been looked at long enough.
Okay, well, I'm going to put both of you on the spot.
Oh gosh.
When the vaccine comes out, when the first vaccine is available, you taking it?
Nope.
John?
Absolutely not.
Absolutely
not.
Oh, I will.
But I hate to break the news
rushed.
to you.
What do you think is going to happen?
Healthcare workers are in
They'll
maybe
probably
not
make
the
us.
first day, but pretty early on, healthcare workers are probably going to be required.
Yeah.
Yes.
That's my guess. No one's saying that. I'm saying that. I think that's what's going to happen. Is the healthcare workers are going to have to take it or not.
Or
be allowed to.
Or not be allowed to work.
That won't be the first day.
So then what are you going to do?
But
Well,
what
then
I'm
you got
hoping
to.
is that I can get tested
Okay,
first
so you will
for the
take it.
antibody.
But I'm not going to seek it out.
So you won't voluntarily take it, but you will involuntarily take it. Okay.
Yeah.
I mean, but what's your okay? So I mean, and I'm sorry. I hope you don't mind.
Are you going to pick on me right now?
Yeah, because I gotta understand how people think. So you won't take it. Why?
I don't think it's going to be very effective.
So you don't think it'll be effective. So you don't want to take it because you don't think it'll be effective.
Yeah, I don't think
because you think it'll hurt you.
I mean, there's always risk with any kind of, medical procedure or medication that you take. So sure, there's some inherent risk, but that's not the reason.
Pretty low. I mean, for like a flu vaccine that can kill you too, but likely not.
Right.
Okay.
Because I don't believe that. I don't do things just because it's recommended. I have to actually think it's effective.
Mm-hmm. Okay.
I didn't take flu vaccines for a long time.
Really?
Yeah.
But we know it works.
Now. But 20 years ago, or whenever I first got into this, it was not even required of healthcare workers to take it.
Mm-hmm.
There was not a lot of data known whether or not it was, effective.
Mm-hmm.
So I opted not to take it.
Mm-hmm. Mm-hmm.
Yeah.
Mm-hmm. It's interesting. I don't.
What do you think,
Joe,
John?
Where is the vaccine for HIV? Where is the vaccine for MERS? Where is the vaccine for SARS? And all of a sudden, those were not the HIV, but the other ones, if I'm not mistaken, are also coronaviruses, correct?
Yeah, I think I think a coronavirus vaccine will be effective. I think this COVID-19. I think it's going to be a vaccine for coronavirus, not necessarily only SARS-CoV-2.
Well, don't you think his point is that we've known about these other coronaviruses for a number of years, and I'm sure people have been working on vaccines for it. They were impactful enough, maybe not here, but other places, that I'm sure there's R&D going on and those types of things, and we haven't heard about a vaccine, and now all of a sudden we have a vaccine?
Sounds to me like it was ineffective governance.
The reason that the vaccines fail, if you read about viral vaccines in general, after 30 years of attempting to get the average vaccine, a huge percentage of them are niched altogether because it takes 5 or 10 years. Why reason I wouldn't take it or try not to take it is I think it probably is effective. It may be effective for 3 months, 6 months, but you don't know the 2-year, 5-year, 10-year complication rate. And this is the reason why most of these vaccines fail. When you look out long term, they end up saying, well, it had this terrific side effect. We're rushing this so fast that we have no idea what the long-term side effects are going to be. And then it looks like even the ones that they're testing, you might have to take repeatedly. We don't even know that yet because
I think they're saying less than annual, maybe even seasonal, like multiple times a year is what I last read.
Or maybe if you have an outbreak.
Yeah, or something like that. But I don't think they're thinking that the early ones are going to have these longer term immunities to last. How we just get the flu vaccine usually once a year. Yeah.
Yeah, I probably from my perspective, I'll take it. So I mean, I know we're going to be compelled to.
Yeah.
But even if we were not compelled to, I would take it.
Well, I also think
you don't say that again. I don't need it anymore. Well, that's what I was thinking too, John. You're concerned about long-term sequelae associated with it, and I'm thinking to myself, you're a little too old to be worrying about long-term.
Yeah, I'm already in the grave halfway anyway.
Oh gosh.
Exactly, both of us.
Well, I think that some effectiveness would be better than no vaccine at all for at-risk populations. So.
But it might work great.
Yeah, and it might. But it would be pretty amazing that we threw one together this quickly when I'm sure people have been working on it a long time. You don't hear anybody saying, oh, we've been doing that for, 10 years and here's this and all we got to do is add on that and now we're going to have an effective vaccine. There's a lot of money to be made in vaccines. So I think the motivation was great even before we had the pandemic.
So the reason that I answered that way, Joe, that I said no initially is I'm saying no to putting it off as long as I possibly can. If it's 3 months or 6 months, I'm sure that it's not going to take very long before we're going to be required to take it, in which case I'm going to take it or not work.
Yeah.
But the reason I'm saying I wouldn't take it right out of the gate is I think if you can even buy 3 months or 6 months and I think you're going to see there's going to be some things that emerge there already is emerging in research. They've already had difficulties on a couple, maybe even 3. I know at least 2. And I think the initial, when you start giving it to millions of people, and the first 3 to 6 months, if you can hold them off that long, they're going to learn some things, and then there's going to be some improvements. Then maybe, if there's a second or third version. But I don't think that you're going to let healthcare workers wait that long anyway. So.
No, I don't think they will either.
Well, and again, this is observational, right? This is my, what I have seen. You and I and John, plus everybody else in our group that is a perfusionist, right?
Are you about to jinx us?
No. Have all had tremendous exposure
He's about to jinx
to
us.
ECMO patients. I have had tremendous exposure. I mean, I was over
You
at
mean
the
COVID patients?
COVID patients.
Yeah, you said ECMO.
Oh, COVID patients, yeah. I was at the Med Center at down in TMC, and my first few days we had 13 and 11, or first week or whatever, patients, that were, and plus an entire, I was on
The
a
whole
unit
unit,
that
the
was
COVID
nothing
unit.
but. It
Yeah.
was like, it was a lot of patients. It was insane. And then just here, in our practice, we've had, we had 5 at one hospital, 5 at another hospital, 1 at another hospital. That was 11.
Well, just
We had 11
think about how this
in
started.
our group.
COVID patients were put in the negative pressure rooms and all those things,
Yeah.
and by the end of it, it was just whatever room was available.
Correct.
And, you know what I mean?
The hallway.
The hall, wherever.
Yeah.
I remember before, we're walking in and you had to go in the
Wear a
ante-room.
papper suit.
Yeah, and you got to get in the ante-room, you got to do this, and you can't even clean the bottom of your shoes unless you're in the
Right.
ante-room, and by the end of it, it's not like people weren't being careful, but it evolved into...
It devolved into becoming extremely cavalier because
Yeah.
it was just too onerous. You can't take care of that many people
You can't.
and do all of that. It's just there's.
So we
you would
have had
to-
great
You would have to
exposure.
triple your staff in order to be able to do all of that stuff.
Or even remember
exactly
when
the way
we
they
were
wanted it.
being questioned when, that we first started screening us.
Yeah.
And it wasn't, have you been exposed without proper PPE and then all the list of symptoms. It was, have you been exposed around anyone at all? And that was going to be an exclusionary factor to let you come work that day at that particular hospital. And
They would have nobody to work there.
right, so
And
they had
to change
they
it.
had to change. They had to evolve
Adapt.
that. Yeah.
Yes, adapt. So my point, though, that I was trying to make is that of the, I don't know, probably, I'll say 20 perfusionists, that I know well personally, that have had tremendous exposure to COVID in the hospital. None of them have gotten it, but I know people
Well, you don't know they haven't gotten it.
have if they've gotten it, they've been asymptomatic,
Correct.
have not had an issue, have not had a problem. But the people who are not exposed,
I know.
like we were, like I was, I know several people.
Me too. My
Who
friend
have-
group.
Yes.
Like, lots.
So what gives? Why?
So-
Do we have something because of where we work?
Because we already have a
because some
heightened
health- yes.
immune response because we're constantly exposed to things.
Yeah, some
I don't-
healthcare workers have gotten
Yeah.
certainly gotten it and had bad outcomes.
Yes.
Some,
Yeah.
but
We worked with some
But-
ICU nurses that, she recovered just fine, but she was out for 2 weeks. Not just for the 14 days or whatever they were
Right.
doing at some point. She was actually ill.
yeah, she was sick.
She was sick.
Yeah,
Yeah. Satting in the low 90s sick.
yeah,
you
yeah,
know?
right. I mean,
So somebody asked me.
very interesting.
Somebody asked me the other day, have you ever gotten a COVID test? I said, no, I won't do a COVID test, but I would do a COVID immunity test to see if I have immunity. And I think that's the first thing I'm going to do. But when the vaccine comes down is what you just said, Joe. I've been exposed, I don't know, 50 or 100 times, and at least. And nurses that spend 12 hours a day with some of these patients, yeah, I know they have the full PPE and stuff, but at some point you have to wonder, maybe we have the immunity, that because we've had such mild exposure repeatedly, we never had the disease, never knew we had it, and they go to give us the vaccine. I think they're going to find, in my personally opinion, that if overall we're going as healthcare workers, there's going to be a significant percentage of us that have the immunity that never knew we had any interaction with the disease that we knew of.
Yeah, but you may not have active antibodies.
Yeah.
So you may get tested, and you have no antibodies, no detectable antibodies, but you still have had an exposure, had antibodies, and now have that memory built in, so that another exposure, those antibodies get developed very rapidly, and can overcome the infection very quickly. So I think it's really gonna, I don't know. I mean, I don't know if really getting the antibody test is worth it, because it comes back negative. It doesn't mean you didn't have antibodies at one point in time, because that's what they're looking for is antibodies.
Even with outside of the healthcare workers, I have a college-age daughter, and they're following the precautions the way college students follow anything. And so they're wearing masks when they have to, and they're not having big parties, but they're still around.
But they're having little parties.
Yeah, they're around their friend groups. They might be around 5-6 people or whatever. And I'm curious why they've had outbreaks in their friend group, but not everyone gets it or don't get sick.
It's so weird.
I mean, my daughter has, because every time that happens, they have to go get tested. The university requires them. I think my daughter might have been tested 5 or 6 times now, negative every time. With
so
close,
weird.
like very best friends, sleeps over at your house, you ride in the car together, you eat together, multiple times.
So weird.
It is weird. I mean, thank goodness she hasn't gotten sick, and lots of her friends haven't gotten sick, but why?
We don't know. I'll tell you what, this will be something talked about for the longest time. I don't know that we'll ever really completely understand it. It's very interesting.
We're so used to being able to figure out and have answers to things in this day and age. We haven't had anything in quite a while that we don't really know. I mean, this kind of reminds me of when I was first, in college, and HIV was really on the topic. Like everybody was talking about it, and no one really knew a lot about it, and we're just not used to not just being able to know something about this is how you get it, this is what happens, this is all these are the treatments, these are the things, or there's no treatment or whatever. So this is, I think, kind of like one of those things.
Biowarfare. It's weaponized. It's a weaponized virus. It didn't come from a bat. You can believe that if you want. But I'm telling you right now,
guys,
this is
how many
modified.
people have you known? Because I know several where the couple they're living together, where husband and wife or adult, boyfriend girlfriend living together, where one of them got it, and they got a little bit ill. They felt a little funny, so they went and got tested. Found out that maybe somebody at work had gotten it. Now they don't feel well. They go get tested, and they're positive. Meanwhile, the other partner never got it. They were sleeping together, lying side by side and living together for 2 or 3 days, which is supposedly the incubation period
and if they weren't,
the infectious period before the person calls ill. And that person still comes home every day, and they distance themselves, but they don't totally live in 2 different apartments now. And then the other person never gets it ever.
Right.
I know something like that.
I know several.
And if they weren't married, they might have even kissed each other. So it doesn't get any closer than that, right?
Well, yeah, I mean.
And yet only one gets it.
It's weird.
It's very weird. Okay, so November 2nd, our next program is on post-cardiotomy extracorporeal membrane oxygenation, no longer a bridge to nowhere. That should also be, and here's another ECMO topic, certainly we've had our share of those.
Yes.
I hate them. They're horrible.
They're horrible.
But it'll be very interesting to see what this article says, and of course we can maybe even contribute to some of how we've managed our cases, because I think, as I said, we've seen it, we've kept them, we've weaned them, we've had them not have positive outcome, and we've sent them to places for more advanced heart failure therapy. So there's a lot of different things you can do. So I like that. No longer a bridge to nowhere, although I think that's been a while. But it'll be interesting to see what this article says.
Yes.
That's on November 2nd. Now, I got to tell you about a program we're going to do. It's not scheduled yet. It's going to be November, I believe it's November 24th. And that's going to be a special program that we're going to do.
Is it
no, it's not
evening?
the 24th. It's going to be on the 14th, November 14th. It's not scheduled yet, but it is going to be, Dr. Badia is going to be talking about the history of wine and its medicinal purposes.
Oh.
And we're going to be getting people information on how to, what wines to purchase. We're going to teach people how to grade wines, how to taste wines.
He's quite knowledgeable in that area,
how to
correct?
pair wines. Yes, he's very knowledgeable, and he has a great lecture. It's a terrific lecture on actually wine as a medicine. It's been being used for very long time, centuries, and that's going to be a really interesting topic. And we're going to have some other folks here. We're going to be probably asking a sommelier to come and also lecture, and I think there's going to be several other topics besides this, but this will be sort of the one towards the end of the program, and I think it's going to be a very interesting show. So that's going to be on the 14th. So Monday, November 2nd, we're doing it in the morning for our European colleagues, and then I think the next one, so then there's the one on the 14th, and then there'll also be one on, after that will be November 19th.
19th, yeah.
And that's a Thursday. So the Monday programs are in the morning, the Thursday programs are in the evening. And John, do you have any final thoughts? I think we're ready to wrap up.
No, I think that sounded great. Great job.
Thank you. Thank
you
you
for
again.
joining us, John.
Yes, and I seriously owe you a phone call. I have been conspicuously missing in action. I apologize for that, but I've been a little bit. It's been a little bit crazy for me. So you know how my life is, but it's settling down.
John, Joe's busy as usual.
Yeah, exactly.
It's settling. Things are settling down a little bit. Okay, I got this last trip out of the country out of the way, and I think things are settling down quite a bit for me now. But I've got some interesting stuff to talk to you about, some interesting ideas, and my trip down there was very fruitful. And I think you're going to really be excited to hear what I plan to do. But I do owe you a phone call, and I apologize for not having reached back out to you since the last time I came out and visited with you. Tammy, any final thoughts?
No.
No?
No.
Very good. Okay, well, I have no final thoughts either, other than thanks very much for joining us.
Yeah, thank you.
I wish somebody would have called in. Eventually, I'm just going to stop putting that doggone phone number up, or I'm going to just call myself from my own phone and be live on the air.
Maybe start getting our, friends and stuff to call
I'm going to have to start offering prizes.
I bet we get some calls on the wine, because I bet people have questions.
Now, that's going to be a great show.
It's going to be fun.
And David, we need to move that on the schedule so that it's before the 19th one, so that we don't get ourselves out of order again.
All right, numbers all messed up.
Yes, I know, like I did last time. Okay, we will see you all November 2nd, 9 o'clock in the morning. That's it. You have any comments or things you want to add, or you want to join us and be part of this faculty? We can make another. David can add a column, and you can be on here too. You don't have to come all the way to the studio, though John does frequently. And I've actually gone to Orlando. We did a show from there, and we want to be able to do that as well. But if you want to be a part of this, send us an email, contact@perfusioneducation.com. In the meantime, have a nice evening and enjoy your dinner or whatever you're going to be doing, and hopefully a very nice weekend coming up. Take care.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae, suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.